I'm Dr. Jack West. I'm a medical oncologist in Seattle and the president and CEO of GRACE, the global resource for advancing cancer education. I'm very happy to have Dr. Lecia Sequist here to present on a very timely topic, and that is the issue of acquired resistance to oral EGFR inhibitors in the setting of advanced non-small cell lung cancer. And Dr. Sequist and her colleagues in Boston have really been among the absolute leaders in the field. And so she is going to speak a little on, give a summary of what is known and what are still the active questions that we're pursuing today. This program is sponsored by Longevity Foundation along with GRACE, and we are extremely happy to have their partnership and support with this work. I'm going to now just turn it over to Dr. Lecia Sequist, who is Assistant Professor of Medicine at Harvard Medical School and Massachusetts General Hospital in Boston, Massachusetts.
Thank you so much for asking me to do this. It's a real pleasure to talk today about strategies for managing acquired TKI resistance, and I'm sure that the audience has a variety of different background knowledge about this topic, so I am going to review at the beginning a quick overview of EGFR mutation-positive non-small cell lung cancer. This may be known information to many, but just to make sure we're on the same page to start. And then I'll talk about what we know about mechanisms of resistance to EGFR TKI inhibitors, which is another way of saying Iressa or Tarceva. And then I'll talk about possible avenues for treating that resistance, including repeat biopsies. And at the end, we can talk about some clinical practical applications and next steps. So just as a summary, the median survival for advanced non-small cell lung cancer has improved over the last 30 years, and we definitely have a lot of room to move and improve further. However, the more drugs that get onto the market, that get approved by the FDA, the more the bar keeps moving up and up. At the very bottom of the screen, you can see that in these boxes, I've summarized what the paradigm of treatment has been. So back in the 70s, if you were diagnosed with lung cancer, there really was many doctors would not give any treatment. They would give best supportive care because it wasn't thought that treatment helped. We've come a long way since then. We went into platinum therapies and then doublet therapies. And what people talk a lot about in the more contemporary age is targeted therapy. And what does that really mean? This next slide is a little bit of a spoof, but this is supposed to represent all the inner workings of a cancer cell, all the connections and the signals and the crosstalk of how the cell functions and how it multiplies and divides. And when we talk about molecular targeting or targeted therapy for cancer, what we are saying in essence is that we can understand this complicated diagram, which in reality is probably a gross oversimplification of what actually happens in a cancer cell, but we can understand it to the extent that we can say this pathway right here is the key pathway, and I want to block that pathway with a drug, and then we take a drug and use that to kill the cancer cells. That's what people mean when they say targeted therapy. And something that my research is focused on is genotype-directed therapy. And that just means that we can take a group of patients in the center of the screen who all have the same diagnosis, non-small cell lung cancer. Even when I was training, which wasn't that long ago, we treated all non-small cell lung cancer patients the same. There was a basic cookbook algorithm. And in the era of genotype-directed therapy, we want to try to be clever enough to separate the green group of patients from the red group and the yellow group, and maybe have a different algorithm for each patient based on their cancer's genotype, just recognizing that not all non-small cell lung cancers are the same. And another analogy that I like to use is that in order to really get to the gold in the safety deposit box, there's really two key steps. One, you need to be able to open the vault, but two, you need to have a key to the individual box that you've got there. And so this represents what I think is our challenge in cancer therapy, is that we not only have to understand the very complicated biology and the inner workings, like that complicated map, the wiring of the cell. We have to be able to understand the biology of the cell, so that's getting into the vault. But we also have to have a very important piece, which is a key to our own safety deposit box, and that's the analogy that I think of as the drug. In some cases, we have a drug that seems to work, but we don't really understand the biology of the cancer well enough to know how to use it. In other cases, we understand the biology of the cancer, but we don't have the right drug that's specific enough or safe enough to give. So really the sweet spot is when you understand the biology and you have a drug that's tolerable and effective. then you can get to the gold or the pearls or whatever you've got inside. So what we're talking about today is EGFR mutations. This is a CAT scan, a chest CAT scan of a patient with an EGFR mutation who had a lot of cancer in their right lung. You can see before was found to have an EGFR mutation, was treated with a personalized therapy, something like Iressa or Tarceva, and just a few weeks later you can see a very dramatic response. That's what we're hoping for, and that's the goal for all lung cancer patients, is to understand the situation enough and have the drugs to get to that kind of response. So how does an EGFR mutation cancer differ from any other type of lung cancer? This diagram is trying to depict the signaling in this cell. Every cancer cell has to receive signals that tell it to grow and multiply and divide. The difference between an EGFR mutation positive lung cancer, which is listed here as gefitinib sensitive, gefitinib is another word for Iressa, the difference between that and another cancer cell is that all these pathways are very reliant on EGFR. EGFR is like an antenna on the surface of the cancer cell, and it sends out a broadcast, and these cancer cells, that's their favorite radio station. They don't like to listen to anything else. Because they're so addicted to that radio station, if you shut it down with a drug like Iressa or Tarceva, you turn off the radio station, then the cells die because they don't have their signal. And this differs from a more typical cancer, lung cancer, that has lots of different antennas or radio stations on its surface and broadcast lots of different messages, so that if you were to block one of them, the cell can still live and persist because it gets signals from other places. So that's the dilemma here. This past year or two has been very exciting because we finally have randomized trials that support what many lung cancer researchers have thought for several years, which is that giving patients with EGFR mutation drugs like Iressa or Tarceva can really make a difference. And many of you may be familiar with the IPASS trial, which was published a year and a half ago now in the New England Journal of Medicine. And this was a landmark trial done in Asia. It wasn't specific for patients with EGFR mutations, but they had a very good clinical selection by doing it in Asian countries where the frequency of the mutations is about 2 or 3-fold that in the western part of the world. And they used patients who were essentially all never smokers. 96% of the patients were never smokers. And they were randomly assigned to receive Iressa or gefitinib, an EGFR blocker, or chemotherapy with carboplatin and paclitaxel. And they looked at how patients did. And if you're not familiar with looking at these types of curves, this is a Kaplan-Meier curve, and we use it to show how well people do on a treatment. The higher the curve stays up towards the top, the better. The faster it drops down towards the bottom of the graph, the worse. The yellow line represents the patients that got chemotherapy, and the green is the patients that got Iressa. And they cross, which is somewhat unusual to see, especially in a clinical trial that is positive, as this one turned out to be positive. And essentially, without getting into too much statistics, the reason why these lines cross is because there are two very different populations within the study. There's patients with EGFR mutations and patients who were negative for EGFR mutation. And when you look at them separately, the lines don't cross, and what you see is that for those who had an EGFR mutation, the green line, or the Iressa, stays up higher longer, and the chemo line drops quicker. This was a very big advance, and I think really changed the mind of a lot of oncologists who were skeptical about this phenomenon of genotype-directed therapy. What the study is looking at is progression-free survival, meaning how long can you stay on the drug before progressing. What I think actually has made the biggest impact in the United States as far as practice in the community is this half of the slide, the right half, looking at the patients who are EGFR mutation negative. As many of you probably know, testing for EGFR mutations is a bit complicated. You need to have enough tissue. You need to have a lab that will do it. You need to have someone that will pay for the testing. Many people thought, we have some clinical predictors. We know that women or patients with adenocarcinoma or never-smoking patients are more likely to have these mutations. Why don't we just use that as a surrogate and treat those people with Iressa or Tarceva? And this right-hand side of the curve is what really, I think, changed practice, because what this shows us, remember, everyone in this trial had adenocarcinoma and was a never-smoker. But if they didn't have that genotype, if they didn't have an EGFR mutation, they actually didn't do very well at all with Iressa, and chemotherapy was much better. So I think this helps convince oncologists that whether or not you have a mutation, you want to give your patient in front of you the best possible treatment for them. Personalized medicine is really appealing for the patient, it's appealing for the doctor, it's a win-win situation. I think that this trial had a lot to do with bringing personalized medicine into the everyday practice of lung cancer. But what we're really here to talk about today is resistance to these treatments. This little cartoon shows the summary of what we know so far about resistance to drugs like Iressa or Tarceva. We already talked about the paradigm here where you have a sensitive cell and you give a drug, a TKI like Iressa or Tarceva, and you shut down all these downstream pathways and you get tumor cell death, which is the goal. There's two main mechanisms of resistance that we know of that are very commonly found. One is a second type of mutation in EGFR called T790M, and what that does is it changes the interaction between the EGFR antenna and the drug. So the drug can no longer get in and block the signal the way it could before. The signal turns back on, the downstream pathways turn back on, and the cancer cell is happy. This is the most common mechanism of resistance. Also, MET amplification has been another established mechanism of resistance that happens in lung cancer models in the laboratory and also has been shown to occur in patients, a smaller percentage of patients. The situation here is that the cancer cell is not getting its signal that it craves, that it's addicted to from EGFR, so it throws up some other antennas. It puts up lots and lots of MET, which is another type of a signaling receptor that can generate similar signals. So it may not be exactly the same as EGFR, but it's close, and the cell is happy and can survive even though it's close enough to EGFR. So these are the mechanisms of resistance that have been well described so far. What I'm going to talk about in the next couple of slides is how well are we doing on what I think is the new paradigm, or how far do we have to go to get to this new paradigm. We talked a little bit about getting an understanding, a biopsy to look at both the type of cancer that you have, but more importantly, the genotype, some of the molecular information at the time of diagnosis, so that you can give a targeted or personalized therapy to a patient, which may be a pill. Many of the newer treatments are pills. But the reason why this is a circular diagram is that that's not enough. After that first targeted therapy stops working, we have to go through the whole circle again. We have to take a look at the clinical information, but I think it's very important to also get a biopsy and try and find out molecularly what's going on now. That's the only way that we're going to be able to move forward and figure out what the next type of targeted therapy should be for that type of a patient. So let's talk in a little bit more detail about these two mechanisms of resistance to Tarceva or Iressa. So T790M, this is that mutation in EGFR. It was initially reported to happen in about 50% of patients, but there have been a number of studies that show that it may be higher, up to 70% of patients who become resistant to these drugs. Our colleagues at Memorial Sloan Kettering published an interesting paper just a few months ago showing that the prognosis of T790M may be slightly better than other types of resistance to Tarceva. And this is another Kaplan-Meier curve. The line on top is the patients that had T790M demonstrated when they became resistant compared to people who were tested and were negative for T790M. As far as how to treat this kind of resistance, there was initially a lot of enthusiasm. This is a relatively old paper from the group here at my hospital looking at a drug called HKI-272, which was made by Wyeth. This is a similar type of drug to Iressa. It's an EGFR inhibitor. It's irreversible. And the thought was from the laboratory work that if you had an irreversible inhibitor, it could get around T790M. And these lab results basically show that in the Petri dish, this worked. You could demonstrate that a cancer would have T790M, but it would be killed off by this drug, HKI-272. So we tried this in patients, and unfortunately the results in patients weren't quite as spectacular as they had been in the Petri dish. This is a study that we just published last year in the Journal of Clinical Oncology looking at this drug, HKI-272, in patients with, in particular, this column here, Arm A, we had 88 patients who had an EGFR mutation, had already been treated with something like Iressa or Tarceva, but then became resistant, and were put on this drug. And only 3% of the patients responded. So that was a little bit disappointing. This is a graph showing the people that responded. Everyone starts off at baseline with their tumor, and if their tumor grows, that's depicted over here on the left-hand side of this curve. If the tumor shrinks, it's depicted over here. So some people had some shrinkage, mild amount of shrinkage. Some people had a mild amount of growth. There were a couple people over here who had dramatic shrinkage to this drug, and that was very interesting. They all had a specific type of EGFR mutation called G719. So that's a little bit off the topic of today, but this drug may be particularly effective in patients with a G719 EGFR mutation. You can also see here that all these little bars where there's a T, that represents a patient where we knew through a biopsy that they had T790M. You can see some of those patients responded a little bit. Most of them did not respond, but there were no dramatic responses in a patient with T790M with this drug that was hoped to be very helpful for T790M. And there are other drugs that are similar to HKI-272 that have been, I would say, equally disappointing in this situation. There's a drug made by Exelixis, which had a 2% response rate in patients who were resistant to Tarceva or Iressa. The Boehringer Ingelheim drug, which now has a name, afatinib, also had a very low response rate, 7%. I'll talk a little bit later about an interesting ongoing study combining afatinib with tuximab, which is an IV treatment that's an EGFR blocker, but it's an antibody. So there may be some success in blocking EGFR through two different mechanisms. Pfizer also has an irreversible EGFR inhibitor, and here, again, the response rate was only 7%. So we initially thought that this class of drugs would be a home run against resistance. Unfortunately, we were wrong in that regard. But remember what I said at the beginning, that you need to understand the biology, which in this case, I think we have a good understanding of the biology. History may prove that it's more complicated. But we don't have the drug. We don't have the key to the lockbox here. So what we need is a better drug. There is hope. There's a new class of drugs that are EGFR inhibitors and are coming forward that are potentially more effective against T790M. This is a structural model of one of these drugs, which currently is called WZ4002. It doesn't have a better name yet, but this drug is not even to the point where it's in human trials. It's still in preclinical trials, testing it in animals. So there are some other drugs that are similar to the WZ compound that are also in preclinical development. So we'll see. I have high hopes for this category of drug, but we're a long way from knowing the answer. So we'll come back to T790M in a few minutes, but let's switch gears for a second to MET amplification. Again, these are some basic science slides that just describe how MET amplification was discovered by my colleague Jeff Engelman. I think this cartoon is a little bit easier to understand. Basically, we've talked about this before, where you have this EGFR-addicted cell line that's sensitive because of an EGFR mutation. One of the key signaling pathways in any EGFR-addicted cancer is through ErbB or HER3. It's also called ErbB3 or HER3. And this goes down through the PI3 kinase and AKT pathway. When you give Iressa, that shuts this whole pathway down. And when you become resistant through MET amplification, basically what MET is doing is it's giving a secondary signal to ErbB3. And so that turns back on this downstream pathway and the cell is happy. The difference between this and T790M is that in order to now kill a cancer cell that looks like this, you have to still block EGFR as well as blocking MET. You can't just switch to a new drug. You have to add something in. So I think effective strategies to treat MET amplification as a resistance mechanism will involve at least two drugs, one that hits EGFR and one that hits MET. To give you just an anecdotal example of a patient of mine, this is a 63-year-old gentleman with an EGFR mutation who, here's what his tumor looked like in his right lung at the beginning, right at the time of his diagnosis. He was treated with Tarceva and had a very dramatic response, but after about a year, which is an average amount of time to be on Tarceva, he developed resistance. This picture here shows a needle going right into his resistant cancer, where we did a biopsy to try and figure out why he was resistant. And what we found on that biopsy was that indeed he had MET amplification. So this is a FISH, a certain way of looking at cells to see the genes inside. And this is his baseline FISH back in 2008 that showed normal copies of MET. Each red probe had a matching green probe, and they were nicely paired. But in 2009, when he was resistant, there was many, many more red signals compared to green signals. And so this showed us that MET was amplified. This patient was actually treated on a clinical trial because of this finding. We put him on a clinical trial of an EGFR blocker plus MET blocker, and he had another response, which lasted for a good long while on clinical trial. So this is just one anecdotal example, but he's one of a few patients who has really convinced me about the benefit, the potential benefit to patients of doing these repeat biopsies. I think we can all understand the benefit for the research community and the benefits as far as gaining further knowledge of doing these repeat biopsies, but I think it's more than that. I think there's actually benefit that could come to patients if we can understand their personal mechanism of resistance and we can then strategize about the most effective treatment to try for them. And there are many clinical trials available around the country, as we'll talk about in a few slides. So just to summarize where we are with MET inhibitors are relatively newer onto the scene than some of the second-generation EGFR inhibitors. A couple of the main drugs are listed here on this slide, but I don't think we have yet a real definitive study that's looking at the question of interest to this group. There is a drug by Arcule and Daiichi Sankyo, ARQ-197, and the trial was done looking at erlotinib plus that drug, but it wasn't in the acquired resistance setting, and it wasn't in patients who had an EGFR mutation specifically. So those results were presented by Joan Schiller at ASCO last year and will hopefully be coming out in press soon, but I don't think that's entirely applicable to this situation. And the same with the MET-MAB drug. This is a monoclonal antibody that targets MET, but again, the first big study that's been presented now by David Spiegel looking at this drug wasn't really designed for the question of acquired resistance among EGFR mutation-positive patients. There's a MET inhibitor by Exelixis called XL184. Results of that trial have not yet been reported. And then our old favorite drugs, which you may not know by this number, 0234-1066, but this is crizotinib, a drug that's been in the news a lot because of its ability to help patients with ALK translocations. Very exciting story for another day in lung cancer. But crizotinib was actually initially developed as a MET inhibitor. So there are ongoing studies looking at crizotinib in patients with EGFR mutations who may have developed resistance to Tarceva due to a MET amplification. So I know that some of this news that I just went over and these results are a little bit discouraging because so far we don't really have a home run as far as EGFR resistance. But there are many ongoing trials looking at novel ways to attack resistance. I've listed just a few here. There's a multi-site trial going on through the Lung Cancer Mutation Consortium with a drug called MM121, which is a HER3 monoclonal antibody in combination with erlotinib. I mentioned before briefly that there's a trial with afatinib, that's BIBW2992, along with cetuximab. That trial is being led by Vanderbilt University and Memorial Sloan Kettering. There's this crizotinib-based studies using the Pfizer EGFR inhibitor along with that. And then there are other classes of drugs that are being investigated, and this list, I'm sure, is not comprehensive. This is just meant to be a representation of what some of the studies are that are going on. Different groups are looking at HSP90 inhibitors, HDAC inhibitors, PI3 kinase inhibitors, mTOR inhibitors, and the list goes on and on. So there's certainly a lot of interest and enthusiasm about trying to find the most effective treatment for EGFR resistance. So what about repeat biopsies? If you're thinking about this with your doctor or you know a patient who's thinking about this with their doctor, the pros of the situation are that you may be able to be altruistic and help the field discover more about resistance to these agents. But I think for an individual patient who's considering a biopsy, the big selling point is that we may be able to uncover information specific to that patient that would help steer them towards the most appropriate clinical trial that might have the best chance of working. Of course, the cons or the downsides of doing the biopsy are the cost and the safety. So I think the cost certainly varies depending on what type of biopsy you do and who does it and what the insurance situation is. So it's hard to put a number specifically on the cost. Safety in the reported series is actually pretty good so far. There's a couple of groups who have talked about the safety of doing biopsies in patients who already have a diagnosis. In other words, you're not getting the biopsy to find out what kind of cancer they have. You're getting it for some other reason. MD Anderson has presented their paper at meetings, and it will very soon be coming out in press about their battle study, where they were biopsying patients to look at different biomarkers, and they had a very good safety record with that. Memorial Sloan Kettering has published their experience specifically in EGFR mutation-positive patients, looking at the safety of repeat biopsies. That's in Clinical Cancer Research last year. Again, they had a very good safety record. Mass General will be publishing our experience in about 2 weeks looking at repeat biopsies, and we also didn't have any complications really. So in general, these biopsies are fairly safe, but that doesn't mean that there aren't other downsides to going through biopsy. It could be painful, it could be inconvenient. There are many groups that are working on other alternatives to biopsy, less invasive, things like looking at circulating tumor cells or different serum markers. There's certainly a lot on the horizon as far as improving that. Are there any other things that we can do to learn about acquired resistance or treat acquired resistance differently? There's a lot of discussion if you go to meetings and talk to lung cancer doctors. Everyone hopes to do combination therapies just because medicine has had a lot of success in treating other diseases like tuberculosis or HIV or even lymphoma, another type of cancer, with combination drugs. And hitting a cancer from multiple aspects at once sure does seem appealing intuitively. Logistically, this can be somewhat difficult to study. Many of these drugs have overlapping side effects, especially the newer targeted drugs that target a specific gene or mutation have overlapping side effects, which can mean combining them is difficult. Then there are all these other political and business type of red tape lines, which is many of these drugs are made by different companies. Companies aren't always willing to work together with another company before their drug is FDA approved for fear that there could be a lot of toxicity that would end up killing their drug in the end. So there's a lot of real-world hurdles to that strategy. We've been looking at whether or not you can identify how cancer will become resistant before you start on therapy so that maybe you could give a combination therapy to begin with that would be more specific for that patient. And then, of course, are there other therapeutic strategies that you could try? Just thinking about identifying the eventual mechanism of resistance for a given patient. In leukemia, there's some data to suggest that these resistance mutations exist before you even start treatment. And we have seen this a little bit when we looked at EGFR mutation-positive patients with an ultra-sensitive assay called the DXS assay. We saw that many patients had detectable minute levels of T790M even before they ever received Iressa or Tarceva. And in general, those patients in whom we could detect T790M had a shorter duration that they were able to be on the drug because they developed resistance more quickly. So that's for T790M. Jeff Engelman's lab has shown that you can also detect very low levels of MET amplification in cell lines, in this case, that were untreated with an inhibitor. I think this is an area of research that's going to be moving very quickly forward in the future. Can we pre-select which patients might develop which type of resistance and try and nip it in the bud, so to speak? So, in summary, the research focus, I think, is genotype-directed therapy is off to a really good start. There's been a huge advancement in this area over the last 5 years, but there's significant room for improvement. There's a lot more questions that we have to tackle, and treatment of resistance is definitely the biggest one. It's proven to be more complicated than initially hoped, but many trials are ongoing, and many patients are benefiting from these trials. I think prevention may be a potent strategy, especially because predisposition towards certain mechanisms of resistance look like they can be identified. And as I mentioned, we need less invasive alternatives to these biopsies. I'd just like to acknowledge some of my colleagues here at Mass General, in particular Jeff Engelman, for the work that we've done together.